Thank you very much for both speakers. Excellent presentations. I'm sure everybody have enjoyed it. So questions. طيب نبدأ من هنا ونمشي بعدين كده نطلع. Okay, عبد العزيز دكتور.
Would you use CAR T-cell antiphospholipid syndrome patients?
So, to my knowledge, there's no data about CAR T cells in antiphospholipid syndrome. CAR T cells are not that simple. You actually do get chemotherapy before you get the CAR T cells, which we call as lymphodepletion. I don't know if you're following the news, but even in malignancy, after 10 years, there have been around 12 cases of secondary malignancy, which showed that it was originated from the same CAR T cell that was manufactured. So still, antiphospholipid relatively is a benign disease. Going that drastic, I don't think we'll have yet any people looking at it at the moment. It's going to take a number of years for no.
Yeah, my question is, sorry, I have a question about the duration of anticoagulation for patients who don't have thrombosis. We have patients, for example, Liebman sac endocarditis or skin lesions secondary to antiphospholipid syndrome. The question is, how long should we continue with the anticoagulation?
Yeah, so all of these diseases that you mentioned, I personally have seen an ST elevation MI, and when they took the patient to cath, the cath was completely clean. So all the clotting was basically in small capillaries that they couldn't do anything for it. So the skin manifestations, the valvular manifestations are based on microthrombi developing in these patients. At the moment, you won't find data based on randomized controlled trial, but just because these patients already have developed these microthrombi, they're prone to develop thrombosis like DVTs and massive PEs in the future. Antiphospholipid probably is one of the highest recurrent risk of thrombosis among different diseases compared to homozygous factor V Leiden, prothrombin, compared to heparin-induced thrombocytopenia is one of the highest. So once you have a diagnosis, we usually recommend to do anticoagulation lifelong. Now, I tend not to use that term. There is very clear data, very clear that above 75 years of age, the risk and benefit flips. So actually, you get more bleeding than thrombus prevention. So I usually use the term extended anticoagulation, as long as the patient is not bleeding in that.
Yes, I have a question. So basically regarding obstetric APS, if it's just APS without lupus, what's your insight about adding on anti-TNF to standard of care? As we know, there is a trial of impact satralizumab in adding on only in APS patients, obstetric APS, without lupus, without SLE.
So I'm not aware of that trial, to be honest. Most of these patients who have pregnancy APS, and I went through the guidelines, I haven't seen that being recommended. What I know and what I practice, as I mentioned, is prophylactic dose, intermediate dose, and next pregnancy, complete anticoagulation with aspirin throughout all of the regimens. Some people will use immediately upfront full dose anticoagulation, but these are very small percentage of people. Anti-TNF, I honestly don't know the data about it, and I wouldn't use it.
I will just comment on this. This paper is not yet out. This is ongoing study. So far, they have only 40 patients recruited, and the use of anti-TNF is not from the beginning of the pregnancy. It's after 11 weeks that it is a viable fetus. And we don't know actually what is the role. Are we doing an anti-inflammation against the trophoblast invasion into the placenta or not at this stage? So still we need to wait. People are speculating that it's going to work. It can be by chance that it's working. So still the study is not out. Every year we are hearing that they recruited extra 2, they completed extra 2. So still we need to wait because we don't still have any evidence to use anti-TNF during a pregnancy.
There are also a case series of very few cases of using anti-TNF in patients with primary infertility without antiphospholipid syndrome, and it's all about the trophoblast invasion and what have you. So some of those studies or some of those cases were successful and others were not. Doctor?
Okay, for Dr. Hamad, Dr. Ashraf. Yes, regarding the non-criteria test for antiphospholipid, like phosphatidylserine prothrombin, that is sometimes associated with the strong antiphospholipid.
Dr. Hussein Halabi works in a hospital that has those antibodies, and they use, not rheumatologists, but their colleague in hematology test them frequently.
Not anymore, by the way.
Not anymore?
They were taken off.
Okay, so you took it off.
Annexin 5 and antiphospholipid.
So those antibodies, phosphatidylserine antibodies, anti-prothrombin antibodies, they do not occur in patients who are negative for anticardiolipin and beta-2 glycoprotein antibodies. Meaning you will not find a patient positive for those antibodies and negative for anticardiolipin and beta-2 glycoprotein. And they are less standardized than compared to the beta-2 and anticardiolipin. So that's why they never made it to the guidelines. Even in the most recent EULAR guidelines, they're not there even. So that's why we don't recommend testing it, and many centers don't have it even. Except for research purposes, that's something else.
I do concur with you, but currently what we are doing in Qatar, we are doing a study of non-conventional measurement of an antiphospholipid, and part of them is the dose test and also annexin 5. So hopefully by next year, because we just finished recruiting and doing all the basic tests for our population, we were comparing seropositive, seronegative. Clinically, they are fitting the diagnosis, but they are seronegative, and a normal, healthy control. So far, the study is a little bit going toward that they are positive. And we were also checking the missing cardiolipin, which is anticardiolipin A, and beta-2 glycoprotein A also. So just in case if they do have any significant and high-risk population. So hopefully the study is going to come up with something. So soon, inshallah, by next year, we will have the statistic analysis.
Mayada? Make it short, Mayada, please.
Thank you for the excellent presentation. My question is for Dr. Ashraf. If we have a lot of patients in their childbearing age came to our clinics, lupus, and we may find that some of them, the antibodies for antiphospholipid, positive with low titer, not that much, and they don't have any thromboembolic events, even they are singles. If we have to start the patient on aspirin, it may help them to get pregnant, or it may increase the risk to bleed or to prevent the thrombosis, because this is or it's according to the patient's condition.
So the data of using aspirin in this population is very weak. And I actually, just last night, tried, because I had this, I used it based on the 2019 guidelines. I started using it. Yesterday, they said somebody's going to ask me what's the evidence behind it. It's very weak. When I looked at it, I thought of changing my practice, actually. So what I usually do, I tell the patients actually what data we have. And it's basically observational studies, retrospective data. There's no strong recommendation. I know it's a very strange wording the EULAR are using in their guidelines, because usually in guidelines, recommendation and suggestion differ in their strength. But here, they're recommending it, I think, based on the panel that was discussing it, not more than that. It's a very weak recommendation. So if either you prescribe it or you don't prescribe it, both are correct. And it's very difficult to make patients understand that either you choose whichever is a correct answer. It's a very hard thing, just letting them to understand that. And then, on the other hand, really the risk of bleeding is not negligible. Yes, it's there, but it's very small. And it's usually in more elderly patients with other comorbidities. I give them the choice and completely let them choose what they want. I don't have a preference, to be honest. Both are correct answers. I know it's difficult, but that's medicine. That's what we have. And just a small comment on the doctor from Qatar that she was mentioning. So I didn't mention seronegative antiphospholipid antibody syndrome, because as hematologists, we don't believe that exists. I know there's a lot of literature in rheumatology about that, but that's where we differ, basically.
The last comment is from my side, and this is probably a teaching activity, since Dr. Attar have mentioned the importance of different lines or subpopulation of the white blood cells, the eosinophils. Eosinophils are very important to monitor compliance. If you put your patients on high-dose steroids and they present to your clinic with a normal eosinophil count, this is 100% non-compliance, okay? Because they should have hypoeosinophilia, okay? And it's the other way, opposite. If you want to follow those patients for adrenal insufficiency, they will have high eosinophil count. Thank you very much, and we're going to conclude our session. Thank you for the speakers.